Hello and welcome to HSE Antibiotic Prescription Aligned series. The content of this video is for educational purposes. Your treatment decisions are your own responsibility.
Welcome to Dr. Wala Adin's notes about antibiotic prescribing. In this lecture, we're going to walk through the management of Acne Vulgaris using the HSE Ireland Clinical Guideline, version 2.0, reviewed in February 2026. Acne is one of the most common skin conditions we see in primary care, and yet it is also one of the conditions most frequently undertreated or treated in a way that contributes to antimicrobial resistance. So, today we're going to be precise. We'll cover everything from classification and first-line topicals all the way through to systemic antibiotics, special populations, and knowing exactly when to refer. Before you even look at a patient's skin, the history tells you a great deal. Always ask about family history of acne. It is a strong predictor of severity and treatment response. Then review their medications. Several common drugs can exacerbate acne, including oral and anabolic steroids, progesterone-only contraception, and certain anticonvulsants. Make a habit of checking this every time. Don't forget lifestyle factors. Whey protein supplements are a well-recognized but commonly missed trigger. Similarly, ask about mask wearing, working in high humidity environments, and the use of hair pomades. And in any young woman presenting with acne, particularly if there are menstrual irregularities, consider screening for polycystic ovary syndrome. Now, on examination, document 3 things clearly at baseline: the types of lesions present, their distribution, and the grade, mild, moderate, or severe. Look for open and closed comedones, look for papules and pustules, and importantly, look for cysts and scarring. Because if these are present at first presentation, referral to a specialist is needed immediately. One final and important clinical note: skin conditions can appear differently on black or brown skin. Make sure your assessment accounts for this. Getting the grade right is the foundation of everything that follows. Your treatment choice depends entirely on whether you are dealing with mild, moderate, or severe disease. Mild acne is characterized by either comedonal disease, open and closed comedones, or by mild inflammatory lesions, meaning a small number of papules and pustules, without significant nodules or scarring. Moderate acne is papulopustular. This means a mixture of comedones and inflammatory lesions, more widespread, more persistent. Mixed comedonal and inflammatory acne also falls into this moderate category. Severe nodulocystic acne, deep painful nodules and cysts, and here is a critical point. Any evidence of scarring elevates the classification to severe, regardless of lesion count. Now, for both nodulocystic acne and acne with scarring, referral to a suitably trained doctor for consideration of isotretinoin is necessary. We will come back to this in the referral criteria slide. Grade carefully, grade accurately. It changes everything about the management plan. Before we prescribe anything, good general advice is part of the treatment. Ask your patient to take photographs to monitor their progress over time. This is simple, practical, and incredibly useful at follow-up appointments. Warn them, topical treatments can cause irritation, especially in the first few weeks. That is normal. They should start twice weekly and gradually build up as tolerated. And critically, set expectations on time. Response to treatment may not be seen for 8 weeks. If you do not tell patients this, they will stop treatment after 2 weeks and conclude it has failed. On skincare habits, advise patients not to scrub their skin or use astringents. These rupture comedones and worsen inflammation. No picking, no scratching. Keep hair away from the face. Use a gentle cleanser and follow with a light, oil-free moisturizer. Sunscreen is essential. High SPF every day, including cloudy days. Many of the treatments we prescribe increase photosensitivity, so this is non-negotiable. And if your patient is asking about hormonal contraception, this is clinically relevant. Favor the combined oral contraceptive pill over the progesterone-only pill, because the progesterone-only pill can be acnegenic, meaning it can actually make acne worse. A small piece of counseling that makes a big clinical difference. Let's move into prescribing, starting with mild acne and specifically predominantly comedonal disease. Your first-line choices here are 3 topical agents. The first is Benzoyl Peroxide 5% gel, brand name Acneside. Apply twice weekly to begin with, increase gradually as tolerated. Once well tolerated, it can be applied every 24 hours. It can take up to 2 months to show effect. Warn your patient bleaching of hair and fabrics is a risk, and there is a photosensitivity warning. The second option is Adapalene, 0.1%, brand name Differin. Same starting regimen, twice weekly, building to every 24 hours. Review at 3 months. 2 important points. It is contraindicated in pregnancy and it must be applied to dry skin after washing. The third option is the combination product, Adapalene 0.1% plus Benzoyl Peroxide 2.5% gel, brand name Epiduo. Same dosing regimen as above, also contraindicated in pregnancy, also carries the risk of bleaching and photosensitivity. For comedonal acne, these are your go-to agents. Start low, build slowly, review at 3 months.
Now, for inflammatory lesions, papules and pustules, your first-line choice is different. Here we use clindamycin combined with benzoyl peroxide gel. Clindamycin 10 mg per gram plus benzoyl peroxide 50 mg per gram. Brand name Duac. Again, start twice weekly, build to daily. Limit use to 3 months if possible, with an absolute maximum of 6 months. Now, an important antimicrobial stewardship rule. Topical antibiotics like Duac must always be used alongside a non-antibiotic topical agent, such as benzoyl peroxide or a retinoid. This reduces the risk of antimicrobial resistance developing. And remember this rule clearly. Do not combine a topical antibiotic with an oral antibiotic simultaneously. This increases resistance. We will come back to this. For mixed disease, both comedones and inflammatory lesions, your first choice is Epiduo, as we discussed. If Epiduo causes severe irritation or hyperpigmentation, switch to your second choice, azelaic acid 15% gel, brand name Skinoren. Apply every 12 hours. Review at 3 months. An alternative second choice is Treclin, clindamycin 10% with tretinoin 0.25%. Apply once daily at bedtime. Do not continue this beyond 3 months without careful clinical evaluation. And the same rule applies. It must be paired with a non-antibiotic agent. 2 rules to memorize here. Pair topical antibiotics with non-antibiotic agents and never combine topical and oral antibiotics at the same time. When topical therapy alone is not sufficient for moderate acne, it is time to consider oral antibiotics. And before we prescribe, 3 guiding principles to keep front of mind. 1. Review the oral antibiotic at 12 weeks. If there is no response, change the plan. 2. Limit treatment to 3 to 6 months per course. 3. If the patient has failed 2 appropriate antibiotic courses, it is time to consider referral for isotretinoin.
Now, your first choice agent is limecycline, 408 milligrams once daily. This is given alongside a topical agent, specifically Epiduo, Differin, Acnicide or Skinneren. Duac and Treclin are not recommended here because combining oral and topical antibiotics increases resistance risk. For limecycline, it is contraindicated in children under 8 years old. It is contraindicated in pregnancy. Advise the patient to take it with a full glass of water. There is a photosensitivity risk, and absorption is impaired by antacids, iron, calcium, magnesium, and zinc-containing products, so these must be separated by at least 2 hours. If limecycline is not suitable, your second choice is doxycycline, 100 milligrams once daily. Same topical agent pairings apply. For doxycycline, contraindicated in pregnancy, not suitable for children under 8. The patient should sit upright for 30 minutes after taking it to reduce the risk of esophageal irritation. Drug interactions follow the same pattern, separate from antacids, iron, calcium, magnesium and zinc by at least 3 hours. One additional note, minocycline is not routinely used for acne vulgaris. If a patient is being transitioned from secondary care on minocycline, monitor specifically for abnormal liver function tests, irreversible cutaneous pigmentation, and reversible drug-induced lupus. The topical agent should be continued both during and after the oral antibiotic course for maintenance. Severe acne is treated initially along the same lines as moderate disease, with oral antibiotics and topical agents. But the key difference with severe acne is knowing when to refer. Referral to a suitably trained doctor, typically a dermatologist, for consideration of isotretinoin is indicated in 3 clear situations. First, the presence of nodulo-cystic acne. Second, failure of 2 different oral antibiotic courses, each lasting 3 to 6 months, with appropriate topical agents used alongside. Not 1 course, 2 separate adequate courses. Third, the presence of scarring. If any one of these 3 criteria is met, you refer. Do not delay. Scarring from acne is preventable, but only if we act promptly. Before referral, it is good practice to request baseline blood tests, specifically liver function and lipids. If the patient is of childbearing age, discuss and commence contraception if appropriate, because isotretinoin is highly teratogenic and robust contraception is mandatory before starting treatment. Know your 3 referral triggers: nodulocystic, failure of 2 courses, scarring. Those are your red flags. This slide is about safety, and the stakes are high. In pregnancy, several of our standard acne treatments are absolutely contraindicated. Do not use Adapalene, whether as Differin alone or as part of Epiduo. Do not use limecycline. Do not use doxycycline. In fact, all tetracyclines should be avoided in pregnancy. They carry a risk of fetal bone and tooth discoloration. For moderate to severe acne in pregnancy, seek specialist advice. This is not a situation to manage alone in primary care. What can we use safely in pregnancy? Topical options that are considered safer include azelaic acid, Skinneren, topical clindamycin, and benzoyl peroxide. Topical erythromycin 2% is also used. For oral treatment in pregnancy, oral erythromycin base or ethyl succinate are generally considered safer options in the 2nd and 3rd trimester. However, the estolate form of erythromycin must be avoided due to the risk of maternal hepatotoxicity. Now, for children, limacycline is contraindicated in children under 8 years old. Doxycycline is not suitable for this age group either. Topical options remain appropriate with suitable age-specific guidance. To summarize, in pregnancy, be cautious, get specialist advice where needed, and avoid all tetracyclines. In children under 8, avoid tetracycline class antibiotics entirely. We finish with something I want you to internalize, not just memorize. Antimicrobial resistance in acne management is a real and growing problem. Every prescribing decision we make either contributes to that problem or helps prevent it. The rules are clear. Rule 1. Topical antibiotics must always be combined with a non-antibiotic topical agent. That means benzoyl peroxide or a retinoid. Always, no exceptions. Rule 2. Never combine oral and topical antibiotics simultaneously. The combination increases resistance without adding clinical benefit. Rule 3. Limit antibiotic courses to 3 to 6 months, not longer. Rule 4. If repeat treatment is needed, use a previously effective antibiotic, not a new one, the one that worked before. On monitoring, remember response to treatment takes up to 8 weeks. Tell your patients this at every consultation. Review oral antibiotics at 12 weeks. If there is no improvement, change the approach. For patients on minocycline transcribed from secondary care, monitor liver function tests, watch for cutaneous pigmentation, which can be irreversible, and watch for features of drug-induced lupus, which is reversible but easily missed. Regarding drug interactions with tetracyclines, for limacycline, separate from antacids, iron, calcium, magnesium and zinc by at least 2 hours. For doxycycline, that separation is at least 3 hours, and the patient must remain upright for 30 minutes after taking it. And as a final word, encourage all your acne patients to take regular photographs of their skin. Progress in acne is slow. Photos make it visible, and visible progress keeps patients engaged with their treatment. That brings us to the end of this lecture. Thank you for watching. This has been an antibiotic prescribing revision session.
If you like this content, subscribe to the channel and hit the like button for more.